Hello everyone. Thank you so much for joining us for this tutorial. So today's tutorial is an AFP one. It's on Introduction to Research and Study Design, and it's given by Beth. So just a few rules. If you're watching via Zoom, any questions or comments that are covered in the moment, if you just want to pop it into the chat, and any questions I can wait to the end, if you just want to pop it into the Q&A. If you're watching on the Facebook Live, just comment your questions and your comments, and I'll pass them on to the tutor. That's all from me now, and I'll just pass it over to Beth. Thank you.
Okay, thank you very much. My name's Beth. I'm currently an F1 doctor at Peterborough Hospital, and I'm on the Cambridge AFP programme for the next 2 years. So today we're going to be covering a brief introduction to research and study design. So in AFPs, particularly the research AFPs, a basic knowledge of research and study design is really useful and often asked about in the interview. So I'm basically just going to be going through that today and giving you like a brief introduction to things. Feel free to ask any questions in the comments, and I'll be watching as we go along, and I'll also answer any outstanding questions at the end. Okay, so in terms of objectives, so I'll just briefly go over where the research element and critical appraisal aspects of the AFP come into the application process. I'm going to go over how you can summarize article abstracts using what we call the Pico model, which I'll go into later. Run through the key types of study design, so thinking about advantages and disadvantages of each and when it's appropriate to use different study designs. And finally, if we've got time, I'll just go over some statistics relevant to the observational studies that I go through. I think this is being covered in another tutorial, but I'll just briefly go over those that are relevant to what I'm discussing today. Okay, so the critical appraisal as a phrase is thrown about quite a lot. And sometimes it's a bit unclear as to what's actually meant by critical appraisal and its role in the AFP process. But in terms of how it's assessed in applying to the AFP, you might be asked about it in your white space questions when you're applying. So some units of application will maybe ask you to design a study to answer a clinical question you encountered, for example. And it's common in the interview to be asked about any papers that you've read recently, in which you'll be expected to briefly be able to summarize that paper and critically appraise its importance. And you might just be given an abstract on a random topic that you haven't seen before, and again be expected to summarize and critically appraise it. So critical appraisal in itself is just the process by which you systematically go through a piece of research, whether that be a whole paper or just an abstract, and you're judging how valuable that information is when applied to a clinical context. So basically you're asking yourself the question, can I use the results of this research to influence my clinical practice? Is it safe to use the results in order to treat patients? So there are many steps to critical appraisal that you need to think about. But today I'm going to be going through summarizing a paper, study design, and we'll briefly touch on statistics at the end. There are other points to the critical appraisal that are useful to bring in, but in the interest of focusing on research, study designs and summarizing, I'm just going to be focusing on these today. So the process of summarising an abstract, we tend to use the Pico model. So Pico stands for population, intervention, control, and outcome. So when you're given an abstract or you're reading a paper and are asked to quickly give someone a brief summary of it, it's good to include each of these 4 factors. So population, thinking about who it is who's included in the study, who is it looking at? Is it looking at a particular population with a certain symptom, of a certain age, gender, or of a particular disease? Thinking about what's being done to that population. So are they undergoing screening? Are they undergoing a surgical procedure or being given a particular service in hospital? And this population, who are they being compared to? So it might be that you're comparing 2 different treatments, or it might be that you're comparing a new treatment to the standard that is currently being offered. Or it might be a placebo and a drug, for example. And finally, what is actually being measured in the study. So if you can summarise these 4 things when you read an abstract, that's really a useful thing to be able to do. And once you've done that, it's important to think about the relevance of the question that's being asked in that study. So is it actually an important question that will influence clinical practice? And has it been asked before? If a study is looking at exactly the same thing that's been previously studied, it might not be that relevant. So I'm going to go through a worked example here. So this is an abstract taken from the Scott Hart study, which was conducted back in 2018. Really, it doesn't matter exactly what the study is about here. You could be given any abstract in the interview, for example, and you're probably unlikely to have read it before. But just stick to your 4 Pico principles. So first of all, thinking about which population is being studied here, what's being done, what's the control, and what is being measured. So I'm going to run through each of these. So in this study, if you just briefly read through it here, the population is patients with stable chest pain. So that's these patients who are coming into hospital complaining of stable chest pain and who are referred to cardiology. That's the population being studied. The intervention that we're assessing is CT coronary angiogram. So this study is looking at whether the use of CT angiography improves diagnostic certainty. And the patients who undergo CT coronary angiogram are being compared to those who are receiving standard care. So this abstract doesn't actually mention what standard care is, but you're comparing this population of standard care plus CTA, consisting of 2,073 patients, to standard care alone. And finally, which outcome is being assessed? So you're comparing these 2 populations and you want to know whether the CT coronary angiogram makes a difference. So the main endpoint or the main outcome that you're assessing is death from coronary heart disease or non-fatal MI at 5 years. And there are also smaller outcomes that are being measured along the way. So it also mentions investigations, treatments, and clinical outcomes were assessed over the time of follow-up. So there are various different outcomes that are being assessed here. I'll just go back a minute. And by just picking out those 4 things and having a structure when you're summarising an abstract, that gives you a broad perspective of the abstract and allows you to convey to whoever's asking about this study roughly what it's about. Sorry, I'm just checking the chat and the questions. Again, if you've got any questions or comments as we go along, please just let me know. Okay, so now that we've covered summarising studies, I just want to go into the different types of study design that we have, covering the main types, advantages and disadvantages of each, and where each type of study design can be applied. So there are 2 broad categories of study type, observational and interventional. So observational, where we're looking at a population, we're not actually measuring anything ourselves, but we're looking at data that's been collected previously. And interventional, in which we're actually implementing measures ourselves. And there are 3 broad types of observational study. So there's cross-sectional, case control, and cohort studies. And the main type of study that I want to cover today under interventional is randomized controlled trials. And these types of studies are actually the types that are most likely to be covered in the abstracts you're given in your interview. The previous study, for example, was a randomized control trial. And when we're thinking about study design, this pyramid of hierarchy often arises and is used. So it basically means that the higher up the pyramid the type of study is, the more reliable that source of data is and the less bias is involved in the study. So as you can see, randomized controlled trials are higher up the pyramid than our observational studies. So going into each of the 3 types of observational study, I'm going to focus on defining each type of study, giving an example, and then the advantages and disadvantages. So a cross-sectional study is where we look at a population at one point in time. So we're taking a snapshot of that population and collecting information on risk factors and outcome at that one point in time. So for example, in a given population, we could ask how many of these lung cancer patients have smoked? And it just gives a very brief snapshot and allows us to look at the prevalence of that risk factor in the population. It's a very cheap and quick study to conduct, and this means that it can be repeated regularly. And as I mentioned before, we get a measure of prevalence in that population of both the risk factor and the outcome. However, it is a very brief snapshot in time and doesn't tell us how things change over time and doesn't provide a follow-up period. And any relationship that we see between risk factor and outcome, we can only really say it's a correlation. We can't really say that it's a cause. Next is the cohort study. So this is a prospective type of study typically. So we're looking at the outcome in patients with the risk factor versus the outcome in patients that are the control group, so that are not exposed to the risk factor. So an example would be how many smokers get lung cancer compared to non-smokers. So you're taking you're taking the 2 groups, the risk factor exposed group and the risk factor unexposed group, and then looking at outcome over a period of time. And this allows us to establish causation as opposed to the correlation that a cross-sectional study can only determine. And it allows us to control data collection, really, because over that period of time that you're following people up, you can choose what outcomes you measure. But it does cost more and is less time efficient because you have to measure things over a set period of time. And it's bad for rare diseases, really, because if you're taking a population now and following them up, if it's a very rare disease, the likelihood of cases occurring in your population, which is just a small sample of the whole population, is less likely. And finally, the case control study is the third type of observational study I'm going to go through. So this isn't prospective, this is retrospective. You're taking patients who have the outcome now and comparing risk factor exposure to people who don't have the outcome now. So, for example, how many lung cancer patients have smoked compared to non-lung cancer patients, in which lung cancer patients lung cancer is the outcome and smoking is the risk factor. So this is very good for rare diseases because you're capturing a sample that includes definite patients with the rare disease. And it's quick and cheap because you're looking at data that's already been collected in the past. And you can examine multiple exposures because you're looking back at the history of these patients, and you can choose what you want to look at. It doesn't establish causation like the cohort studies, and you are reliant on records that have already been collected. So although this is quicker and cheaper to look at previously collected records, if they're not very reliable, that affects your study. And also, if you're asking patients with and without lung cancer whether they've smoked in the past, you're relying on their memory. So we call this recall bias. And again, that might influence your results. So I've just included a table here to kind of visualize these types of studies in a bit more detail. So if looking at the middle column, start of study, so I just wanted to show and picture where the risk factor and outcomes are being measured. So with the cohort studies, you're collecting information about the risk factors at the start of the study and looking at outcomes in the future. And with the case control, you're collecting and capturing a population based and looking at outcomes at the start of study and looking back at risk factors. So most cohort studies are prospective, but you can get retrospective cohort studies. So this is still that you're looking at outcomes. You're going to measure outcomes in the two in the exposed and unexposed groups, but you're not waiting for the information on outcomes to be collected over time. These will already have been collected in the past, and you're analysing that over time. So, for example, the study might have started in 2010, and the outcomes were measured in 2019. So you've got all the data to hand that's already been collected, but it's shifted into the past rather than, for example, starting the study now and waiting for the outcomes in the future, which would be a prospective study. So it's different from a case control study, even though it's also retrospective. but does have the disadvantages of case control in terms of relying on patient recall and the disadvantages that I mentioned in the previous slide. So that's covered all the observational studies. Now I'm going to go into a bit more detail on randomized controlled trials, which is a type of interventional study. So in these studies, patients are randomly allocated to either an intervention or a control group, usually. So there are two main types of randomized controlled trials, parallel and crossover. So parallel is the type that's usually used, in which patients will be assigned to the intervention group or the control group. So, for example, the intervention group might be a new drug, and the control group might be a placebo. So this is the most common that is conducted. But there's also a crossover type of RCT, and this is when patients are initially allocated to one of these groups. So using the same example, the new drug or the placebo, but then after a period of time they're swapped to the other group, and this allows the patients to act as their own controls, and there's usually a period in between them being swapped called the watershed period, in which all treatment is stopped, which means that you can allow a period of time in which one is not influencing the other. And this is particularly useful in that some studies where there's really a probable likelihood that the drug of choice being studied is beneficial to patients. Patients might be reluctant to sign up to trials if they think they're going to be assigned the placebo. So by offering this type of study, you might find that it's easier to recruit patients because they know at some point they are going to be exposed to this drug. So if they're suffering from a disease that they would ideally like to receive a treatment for, they're more likely to sign up for these types of studies. So RCTs in general, regardless of whether they're parallel or crossover, they're really good for establishing causality, and they're higher up that hierarchy pyramid. There's reduced bias, and the results are really more reliable than observational studies. But RCTs are a lot more expensive and labour intensive. And there's a lot of ethical considerations to think about, because by assigning patients to interventional and control groups, you're potentially omitting them from a beneficial treatment. So it's worth thinking about that when you're discussing the advantages and disadvantages of RCTs. So why do we not always conduct randomized controlled trials if they are the most reliable that we can use? I mean, even though they do have less bias, some studies are a lot more suited to different scenarios. So cross-sectional studies are really good at studying diagnosis and prevalence of different conditions. Cohort studies are very good at studying prognosis. And randomized controlled trials are very good at looking at causation and thinking about potential treatments. So it's not always the case of just because it's higher up the hierarchy, it's better. It's about suiting the study design to the question being asked. Okay, so I've got a question here, just to check what we've gone through so far, and I'll share the poll so that you're able to answer it. So I've very briefly outlined an abstract here. And I'm going to open up the poll to ask you what type of study this would be based on those that we've covered so far. So I'll give you a few minutes to think about it and answer. Okay, so I think of the 2 attendees able to vote, both of you have voted now. So I'll just end the polling there. Okay, so one person said case control and one person said retrospective cohort. So in this case, what we're looking at is diet information and cases of ovarian cancer. So we're taking a population in which there's ovarian cancer and non-ovarian cancer patients, and then looking back at the risk factor of diet. So ovarian cancer is the outcome and diet is the risk factor. Because we're taking a population and looking back retrospectively in time, this is an example of a retrospective cohort study. So this is an example of a case control study. So you're looking at 2020, so it's present time, and you're looking back in time. Yeah. So it would be a retrospective cohort if you were looking at a period of time which was completely in the past. So if it was 2000 to 2010, for example, but in this case, it's really up to present time. So it would be retrospective in terms of case control rather than a cohort study. I hope that makes sense. Okay. So in terms of statistics, I did mention I would briefly be touching on those relevant to some observational studies that we've covered so far. So relative risk and odds ratio are two statistics that are used in application to observational studies. So relative risk can be applied to cohort studies, and it compares the probability of risk factor positive and risk factor negative groups from developing the outcome. So this makes sense when we're thinking in terms of a prospective study. Odds ratio, on the other hand, is used in case control studies. So it's used as a retrospective measure, looking at the odds of exposure to the risk factor in patients with the outcome compared to those without the outcome. And this table is really central to calculating these two values. And these calculations are often things that can just be asked in the interview. You might be asked to quickly calculate an odds ratio. So just knowing these two formulae and being able to apply this table to a specific study that you're being asked about just allows you to quickly calculate these values. And really it's just a case of plugging them into the formula and calculating. and usually they're quite easy numbers to calculate, and you're able to do it in your head or quickly on a bit of paper. So here's a worked example. So taking the table, if we're thinking about disease and exposure, we could think about MI and smoking. So what this table is showing is how many patients with an MI smoke, how many don't smoke in C, and then how many patients without an MI smoke, and how many patients without an MI don't smoke. So by plugging numbers from an abstract that you might be presented with in your interview into this table, you're able to apply these into the formula to calculate relative risk and odds ratio. So here I've just showed how it's basically just a case of plugging them into the formula. So applying A, B, C, and D into these. These were not the most straightforward of numbers to use, so they're not particularly nice round numbers. But in the interview, if you're ever asked to do this, they will usually be nice numbers. But it's just really useful to be aware of that you might be asked this in your interview, and I would just memorize those two formulae and be adept at using these exposure disease tables to kind of organize your thoughts and be able to quickly calculate these statistics. Okay, so that's the main things I wanted to cover today. So I've covered summarizing an abstract using a systematic approach, so the Pico method. I've run through the key types of study design, how to recognize them, and the advantages and disadvantages of each. And just gone over calculation of odds ratio and relative risk. I haven't gone into a lot of depth on statistics, but I just wanted to make you aware of the fact that you might be asked to calculate these and that they're useful for assessing, quickly assessing numbers and statistics in a study that you might be given in the interview. Okay, so that's the end of today's presentation. If you've got any questions at all, please just add them into the chat or the comment section, and I'll be around for the next few minutes and answer those if there's any questions. And if you can just, there's a URL here or a QR code that you can scan just to fill in a feedback form, which would be really helpful if you're able to. Thank you very much.